The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is the week where we get to grill our guest of the month, and Dr. Peter Lindgren has been kind enough to agree to come back. Welcome back, Pete.
Thanks, Paul.
Let me ask you some questions. We got some great questions. Are you ready?
I am ready. Oh, and by the way, I don't have anything to disclose. And I was thinking I probably should get some like soap sponsorships so that I could disclose something, but hasn't panned out.
Okay, we'll see what we can do. We'll take that one offline. Question number 1. What should I be telling parents about choosing products to bathe their baby? Should they use Dr. Lindgren's patented baby bath?
If only the way that we could pay for fun vacations. Paul, I don't know about you, but I don't usually tell people what they should use unless they ask. And even then, I guess there's sort of an array of things that are around. I don't know if you know this, it's about an $18 billion a year industry.
Wow.
Yeah, so it's pretty big. And I think people are pretty impressionable and vulnerable. So, they'll do whatever. But, I think the advice really is use a gentle cleanser. And then, the next question is, well, what's a gentle cleanser? And I don't know if you've looked at, these things, but, the advice is to use something that's neutral or mildly acidic, remembering kind of that, establishment of that acid mantle, which probably helps as a protective barrier. But I don't think most of those things like say what the pH is, but most of the just baby products are fine. And, there are lots of different brands. Johnson & Johnson, Cetaphil, and Vanicream all make, different things. But I think, just telling people to get something that's gentle and not too expensive is probably reasonable.
And scrubbing probably is necessary.
Yeah, and I think people do kind of seek your advice on this. It's probably wise to tell them that babies don't need a bath every day.
Yeah, you could say that it goes without saying, but it doesn't. I think that the things that you've been telling us about, the things that we do to try to cultivate the health of a baby's skin, would argue that we approach the process thoughtfully.
Yeah.
There you go. Question number 2. What should I be telling parents about moisturizing their baby? Should they use Dr. Lindgren's patented baby? No. When do babies need to be moisturized? Are there products that should be used or avoided? Because this one comes up all the time, right? Especially because when babies are peeling a little bit, and in Utah especially, it's dry. And so people always ask about moisturizing.
It is. I think, again, helping people understand that peeling that happens kind of in the, end of the first, second week is just a normal process, and they're not typically, dry, but, like reasonable to use lotions if you want. Personally, I'm a bit of a minimalist when it comes to those things. I don't think you need very much. One thing that we probably mentioned a little bit is that there are some studies that suggest that having a disrupted epidermal barrier may increase your risk for things like atopic dermatitis. So there are some studies that have looked at using, different emulsion-based emollients for that, but I'm not sure that that's something that everybody needs to do all the time. And I think, again, doing those kinds of things when babies are dry is probably reasonable. I think the thicker creams, particularly when it comes to, trying to moisturize and hydrate the skin, are probably preferred. And so that's probably kind of the angle to go down. And I think it'd be interesting to see whether or not, there are some studies that end up looking at and maybe kind of helping define better strategies for prevention of atopic dermatitis down the road.
Well, it is interesting, isn't it? I think we are thinking more in terms of this kind of holistic approach, that the things that we do matter in terms of helping to set up the way that skin functions very long term.
Well, and isn't that sort of our job, right? Is to kind of try to set people up for, like maximizing success and decreasing their likelihood of having problems.
And to some extent, trusting that nature does things pretty well very frequently.
Yeah, it does. And, it's sort of like one of those things that what do mothers do when their babies are born, but put them, to their skin. And there is that transfer of like nice, normal microbiome stuff from the mom to the baby. And so there are all those things that are happening, but, they kind of happen just because that's, what is supposed to occur. And, kind of fun to try to understand sort of like what the advantages of all those things are.
Let's be honest, somewhere, somehow, there's going to be a market for donor vernix. I see this happening. What about antimicrobial products?
Yeah, so this kind of stretches, but there were these studies that looked at, bathing babies in like chlorhexidine after delivery. And this was sort of in developing countries and looking at incidence of newborn infections and stuff. I mean, obviously, we don't do that. And I think the other question is, do those things offer any advantage in preventing things like omphallitis? And the answer to that is they don't. So, it's maybe not one of those kind of advantages. And again, while you may want to decrease pathogenic bacteria on the skin, you don't want to get rid of all bacteria in the skin, which also perhaps inhibits the growth of those other things. So I would say no advantage to antimicrobial products for newborn skin.
Sounds reasonable. Should parents be concerned about hard water and its effect on baby's skin?
Well, we kind of have hard water here, don't we?
We sure do.
I don't think so. I don't think there's any real convincing evidence that it has like any significant health effects. That said, I do think that basically hard water, I think with the kind of higher calcium and magnesium content, tends to be better at, I guess, I'm not going to know the chemistry of this very well, but basically it can kind of be more of an irritant to the skin and perhaps is somewhat problematic for the potential development of things like atopic dermatitis. But the kinds of things that I looked at basically didn't really show that there's any real advantage of using water softeners at home to reduce the severity of those things. So don't go buy a water softener.
But you're not making any particular recommendations here. Okay. Here's an interesting one. I understand that babies have a slower blink reflex just after birth. How can that help parents protect their baby's eyes?
Is that really true?
It is.
Huh.
Not get soap on them. Next question.
I don't know that I've ever run into that as a problem.
You can make a problem of it out of anything, Pete.
Maybe it's an advantage, Paul. They've got their eyes open. They're looking at their dear parents and forming these amazing kind of images, and maybe you don't want them to blink.
Okay.
Did you know that people don't blink as much when they look at computer screens, and that's why their eyes dry out more?
Is that right?
Yeah. Maybe we should have babies look at, no, never mind.
Okay. All right. Next question. Are there other infectious conditions besides HIV that would make us recommend earlier first baths?
The only one that the AAP explicitly says you should do early bathing for is HIV. However, if a baby was born and came out and was exposed to active HSV lesions, that would be an indication for bathing. And I think a lot of people think that bathing, if you have, mom who's Hep B or Hep C, mainly because of the contamination with other caregivers, it would be reasonable to bathe those babies early. When you think about the kind of delay of bathing, the main reasons, perhaps better breastfeeding rates, right? So maybe a little less hypothermia, maybe a little less separation from mothers is the thought. But there's no recommendation to suggest that you would do it, in a GBS positive mom.
And I don't remember, did you mention, or is there recommendation based on babies who are meconium stained?
Um, well, I think no, there's not. I mean, I think it's reasonable to, I think, wipe down babies. I think, oftentimes what happens, practically speaking, is that babies are going to have their faces and heads and stuff, washed off,
Yes.
with a cloth, particularly if there is a significant amount of meconium present.
Okay. All right. Can you make any recommendations about protecting a baby's diaper area in the first weeks? It seems the diaper rash is quite common in that period.
Yeah, I mean, this is kind of common sense, but change the diaper a lot, right? I mean, babies poop and pee quite often. I mean, that whole loveliness of the gastrocolic reflex gives babies frequent
Yeah.
stooling, frequent peeing. So, trying to keep babies, from having contact with urine and feces is really probably the strategy mostly. And, I think sometimes people are like, well, the baby hasn't pooped, so they're just wet. You should change the diaper if they're wet, right? And then I think using really kind of, gentle technique when you're cleaning the diaper is really good. And then if there is any kind of redness or irritation, zinc oxide based application is probably the best. And one of my family practice colleagues one time told me to put the diaper cream on like frosting on a cake. And I thought that was really a lovely image, but really good advice. You don't want to just have a, really thin layer of protection, that it's fine to have a nice thick layer. And particularly because diapers are rather absorbent, the diaper oftentimes takes off a fair bit of that layer. So nice, generous amount of zinc oxide is lovely.
Well, it seems like then that there'd be less likely mechanical harm if you don't feel that you have to scrape all of it off with every diaper change. You've Teflonized a baby's bottom in a good way.
That is one of those points, isn't it? Right? That you don't have to take it off. I mean, you might get the stuff on the top.
The friction is substantial sometimes, I think, in the sorts of wiping that you do. So
yeah,
yeah,
no, for sure.
All right, brace yourself. This is a long one about vitamin K. All right, put your feet up. In looking at vitamin K practices in other countries, there seems to be a lot more support for oral vitamin K administration in some other countries, for instance, the Netherlands, Germany, France, Switzerland, Denmark. Though from the data I can find, there seems also to be a concomitant increase in vitamin K dependent bleeding in the oral vitamin K regimens there. So what do? You talked about the mechanisms for getting oral preparations for people who prefer to avoid the injectable version. Do you know if anyone's working on simplifying the process? Is there a venture capitalist somewhere coming up with an expensive oral preparation for?
Paul, there's a problem with this. And the problem is that we have a simple, effective solution, right? We give IM vitamin K.
Mm-hmm.
So,
and it works.
Yeah. Right? So the hard part is, why would anybody develop something to kind of fit that market of stuff? So, again, there is only a 5 milligram tablet of vitamin K that's available in the US. So crushing up tablets and giving it to newborns is difficult. So the IM dose can be given orally, but that's hard to get and it's expensive. If you compound the oral stuff, it has to be refrigerated and doesn't stay in solution very long. So while pharmacists can make a suspension, it's practically hard. Compliance with those regimens has been shown to be poor. And then the hard part is, as we begin to say to people, you could do oral vitamin K, it's almost like endorsing that as a equivalent solution for prevention of vitamin K deficiency bleeding. And that's, I think, kind of one of those hangups that is out there. So would I, if I had somebody who I could not convince to do the IM vitamin K, would I bend over backwards to get them to do oral vitamin K? I would. Is it easy? No. I think there are a lot of people who they're going to take these routes on their own and go around us. I think it's a little bit of a hard issue to decide to endorse doing oral vitamin K when you know that it's an inferior solution for prevention of vitamin K deficiency bleeding.
I mean, it seems to me, as I look at the issue, and I don't understand it extremely well, but as I look at the issue, in places with really good healthcare systems, places like, Germany and Denmark. It seems to me that the solution there isn't that it's in any way superior, but that it's something that people will accept. I don't know.
Yeah, I mean, I still think we have really interesting issues. I think in general, people don't like being told what to do.
Mm-hmm.
So, I think we have a duty to inform people, give them good information, and then partner with them and nudge them as hard as we can to like do the right things. And, it's a difficult one. We're in an interesting place historically with people having a lot of information, and they're being informed by sources that may not be giving them really great information, but they're getting information and they're making decisions on it, and they may be kind of weighing those kind of pieces equally with things that we would consider to be more vetted, researched, critically analyzed.
Yeah.
So
no, you're right. I think the difficult thing is I think this is an area that requires development of trust and good communication. And I don't think there's any shorthand for that.
Nope.
Yeah. All right. I don't know if this is a hardball or a softball question. This question comes from me, Paul Wirkus. Some parents told me recently that their baby didn't need vitamin K because they had done delayed cord clamping. I don't think that's true, but is that a thing that some people teach?
I've never heard that before.
Okay.
That certainly would not increase vitamin K levels.
I think that's an illustration of your previous point. There are a lot of people who say a lot of things, and unfortunately, it's very difficult, I think, for the average person to vet that in a meaningful way.
There's so many complex things to think about and consider. So, yeah, I mean, sometimes, we just jump to those kind of quick things, right? And I almost wonder if somebody heard something like that and it was not even related to vitamin K, right? Yeah. They might have been thinking that they did delayed cord clamping and they knew that their baby got a little something of iron, right? Because they do get more cells of their own coming back, right? So, you could almost imagine that someone might confuse that their baby got more iron, so they don't need to do,
right. That there's an equivalent somehow,
right,
that you got a blood thing, and so, maybe so. Yeah. Whenever I think of don't discount the natural things, I'm reminded many years ago of some series of case reports about people who were treating babies' umbilical cords by packing them with dirt. It was a cultural thing, and a series of cases of tetanus that came out from that natural is not always superior.
Yeah, no, not always.
Well, you want a softball question to finish up on?
I'm ready at the plate for your soft
pitch. This is soft pitch. Yeah, this is soft pitch. It seems nice to be able to have an EOSR score calculated for you as you do at Intermountain. If I'm trying to do that at my hospital, how do I decide? So if I'm using the Kaiser calculator, for instance, how do I decide which incidence figure to use?
It's probably safe to just pick the CDC incidence, which is 0.5 per thousand. So that's reasonable. And that's probably going to give you kind of the middle of the road incidence, not too high, not too low.
Sounds like fun. Correct me if I'm wrong, but after Intermountain looked at a lot of babies and looked at their data, it turned out it was about the same as the CDC data, right?
Yeah, I should know this off the top of my head, and I don't. I feel like ours is a little bit lower now. 0.3 for
oh my goodness,
and 0.3 for 2023. So
okay,
or 0.32 to be more accurate.
That's significantly lower.
Yeah, it is a little bit lower.
But using 0.5 even in our market would at least make you not underestimate the risk.
Correct.
All right. Well, Pete, thank you so much for your time. This has been very, very interesting. Hope we can chat again sometime. Offline, obviously, I hope we can chat again sometime. It would be nice to do this officially again at some point. Thank you so much for spending some time with us this month.
Thanks, Paul.
And to all our listeners, make sure and recommend this to your friends and family and neighbors and whoever else you meet. Thanks for listening. We'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.